This is Meredith, Jasmine, and Brittany from Nursing 511. We're going to talk about nursing theories and how they apply to our practice. The theory that I'm going to discuss is a theory of general adaptation syndrome. This theory was developed by Hans Sell and is based on the body's fight or flight response. It describes how the body responds to stress and is called the general adaptation syndrome because it involves generalized changes that affect the body. According to our textbook, the fight or flight response prepares the body for muscular activity when reacting to a perceived or actual threat. This reaction increases the heart rate, respiratory rate, blood pressure, and blood sugar levels. Blood is shunted to the muscles of the legs, heart, and lungs from the intestines. For this theory, Sell developed 3 stages of stress that describe how changes in organs occur. The first stage is alarm. This is when the fight or flight symptoms occur. The second stage is resistance. This is where the body returns to normal or maladaptation causes a decreased level of physical functioning. The third stage is exhaustion. This is when organ systems show evidence of deterioration. I apply the general adaptation syndrome theory to my daily nursing practice. I work in the emergency department and I see many patients every day that come in for illnesses related to stress. I educate my patients with elevated blood pressure, elevated heart rates, asthma attacks, anxiety attacks, and gastric ulcers that stress can cause or exacerbate these symptoms and illnesses. Another time that I use this theory in my daily practice is when a patient is brought into the ER from a motor vehicle accident. Most of the time, the patient's heart rate is elevated, they're sweating, they have an increased respiratory rate. The patient's symptoms coincide with the first stage of stress, according to Sell. I explain to the patient that they are experiencing these symptoms because their body is under stress. I chose the general adaptation syndrome theory because it justifies our reasoning for symptoms or illnesses in the ER. Oftentimes in the ER, when we cannot find any medical illness to blame a patient's symptoms on, we blame it on stress. I, as the nurse, educate the patient on stress and send the patient home with information on how to deal with stress better. The general adaptation syndrome theory is a great theory that applies well with my practice as an emergency department nurse.
Cool. Thank you. I'm going to be talking about chaos theory. In chaos theory, the belief is held that systems change and survive because of agitations to the natural balance or the homeostasis of our bodies. For example, aging over time. These changes subtly affect the trajectory of the system. The example that's given in chaos theory is called the butterfly effect. And we're asked to think of it as the wings of a butterfly making ripples over water, and over time the ripples of water grow and can change and become more turbulent and can eventually cause a tornado in another part of the world. I like applying this theory in practice because as human beings, we're all really different. We all have different motivations. We all have different belief systems and environmental factors. Your political affiliation, your socioeconomic factors that affect our lives and how we live it. And if we can embrace the naturally occurring chaos that exists in our patients' lives, we can introduce information or like these subtle changes that can create more individualized interventions in a person's overall health. I work in the emergency room as well, and I often find that people come in because they're really scared. They're nervous about a life event that just happened. You may have somebody coming in with chest pain, and it may be from an anxiety attack. It may be from something else, like maybe either an AFib or maybe something is happening cardiovascular wise, but this is described as a key vector. This is the chaos that's going to cause change in their lives. So for example, I might have a middle-aged man that's a little bit overweight, and maybe he's going through a lot of stress, and that anxiety is causing chest pain, and he's afraid that he's having a heart attack. After we find out that nothing is physiologically wrong with him, I can introduce all of these little key vectors, or I can introduce all of this new information that he can use, just to kind of create motivation in his head so that he can make overall life changes. Taking a baby aspirin every day, possibly adding walking, taking away some stress. So something like that key vector, that scare that this person had could actually be good for the overall health. And I, as a provider who have a limited amount of time with this person, can kind of control the future trajectory of their health that way. In a study that I found by Resnick Page called Embracing Complexity and Chaos, they kind of give the example of and a human is not going to attach to all of these ping pong balls. Only a couple of them will attach to them, and then that's how humans will change their motivations. It's so individualized, it's super random, and we really can't predict what's going to go on. So I chose to use my dog, and I have a couple of balls. And it says that we can't predict what's going to go on. All we can do is kind of throw a couple of balls in there, and whatever is going to attach is going to attach. So I just thought that I would get Rosie. And I'm going to just throw a couple of balls out there. So maybe this is aspirin, and this is eating a little bit healthier, and this is going to be exercise changes. I'm just going to kind of throw them up, and she's just going to kind of try to catch them. And whichever one she goes for, I don't know what it's going to be, that's going to be the key vector that's going to make a change in her life. So that's it, and that's what I chose to talk about. Thank you.
Can't hear you.
Can you hear me now? Sorry. I think that was a really good example of using your dog, because in all honesty, we don't know what our patients are going to choose. I mean, we can only educate them to the best of our ability and hope that they choose the route that we believe is best for them. But at the end of the day, they will just choose what they believe is best. That was really good. The theory that I chose is the development or ego development theory by Erickson. This contributes to so first of all, his theory has 8 stages of development, and he stands out among other theorists because he actually goes all the way into adulthood, like the development of adulthood, and other theorists stop with adolescence. So I feel like that makes him different. And just because as an adult doesn't mean that you are fully capable of caring for yourself and your developmental level, it doesn't mean it has to be at the adult level. We can be below the adult level. So I think that's really important when trying to make therapeutic goals for your patient. He also explains that it's a mutual fit between the individual and the environment, which our individual, the way that they want to care for themselves in different environments is huge, because just because in the hospital, patients tend to kind of fall. I feel like, in my opinion, I work at a neuroscience unit, which we see a lot of strokes and a lot of patients who are not capable of taking care of themselves. But we also have those patients who are capable of taking care of themselves, but they kind of decide to let the nurse or the tech or their family to care for them because they feel as if they're not capable enough, which I feel like will prolong their stay. The way that it contributes to practice is when we go in to assess our patients, we need to determine their developmental status or age to find out where are they developing, where should our goals be, what's going to be appropriate at this time in their life, with their environment, what's going on, and do they understand what's going on, or is it more as if they have no idea what's going on and you're just caring for them 100%. Applying this theory into practice is not only as a nurse, but we have to figure out their developmental level, because if we have a patient, I'm going to use my unit for example. So we have a lot of patients who don't get up and walk, who don't care for themselves, and we need to know what are they capable of doing to help physical therapy, occupational therapy, speech therapy, to give them well-rounded quality care to kind of get them on their feet and see how far we can get them before discharging them home with rehab or into a rehab facility with home health, with family care, just depending on what the family wants and the doctor's recommending. I also chose this theory because I've learned about it in psychology, and I feel as if no matter where you are in nursing, whether it's pediatrics, babies, adults, it applies no matter what. So it's a good theory to look at, because right now we may say we want to go into one practice of nursing, but later down the line we can change, but this theory can still be applied to that. One of the concepts that is related to my theory is ego strength, which is the assessment and intervention the nurse can also use to empower the client to take control of his or her life, to deal with the problem that they're experiencing at the time. Sorry, bear with me. I don't like talking.
That's okay.
So achieving those goals, we have to make the most realistic goals for our patient. And if you're just going to make goals off the bat and not understand where they're at, they'll never achieve those goals. And we want them to achieve at least majority of their goals before going home. So I really always stress to, like if I'm precepting, when I ask the nurses that I'm with, I always ask them, like, what do you see this patient achieving? We have to make them as realistic as possible, because if they don't feel that they're going to achieve something, they'll lose motivation in their care. And we really have to get our patients to care for themselves as much as possible, because that's going to get them out faster. They're going to recover quicker. They're going to feel as if they have more to life, more to look forward to, more to live for. And instead of I had a patient who, he could not achieve any of the goals that they were making for him, and he became very depressed, and he would not participate in physical therapy, not occupational therapy, because the nurse didn't take the time to find out, okay, what can he achieve and what can't he achieve? And he wasn't achieving anything, which completely threw his quality of care off, because nobody could get him to partake in anything at all. They didn't want to get up to the wheelchair, didn't want to. Every time physical therapy came in the room, he would send them away. Every time occupational came in, send them away. The nurse would come in. We try to give him meds. He wouldn't even want to take them, because he said he didn't feel as if, what's the point? I'm not getting better. I'm not seeing any improvement. But that's because those goals that they had set for him were not realistic. So I don't know if you guys can relate in any way. In the ER, I know it's sometimes a little bit different. You don't seek care for that patient as long, but we see patients for 2 weeks, months, 2 months.
I used to work in a neuro PCU over in mental health, and it was really similar. But I mean, even in the ER, you have your frequent flyers, you have your addicts, and you see them literally all the time, like maybe once a week, and you're always doing something. And you always try, because you do get to know them, and it's unfortunate, and all of their life situations, and it's kind of the same, like what is it that motivates this person so that they're not coming back here, so I think that it is relatable even in our field.
Yeah.